maybe just excited about this.
Coming today on a Friday, I know this is not our usual cardiology round. It's a very special one. Today we have the great pleasure of having Professor Jose Zamorano joining us with his team from Madrid, Ramón y Cajal Hospital, which is largest hospital in Spain and one of the largest, most important ones in the whole European continent. Professor Zamorano is a professor of medicine at the University of Alcalá in Madrid. He's the chief of cardiology at Ramón y Cajal. I've known him for quite a few years. He graduated from Universidad Complutense in Madrid in 1987, became a doctor in medicine in 1991, and got board certified cardiology in 1993. He has been among the leading researchers in different topics, including heart failure, ischemic heart disease, probably most broadly recognized for his work in valvular heart disease. He has published 700 articles, 20 books, including the European textbook of cardiovascular imaging, which is competing with our here, and doing much better. Professor Zamorano has been very active in the European Society for Cardiology, where he was served as the vice president of the society, secretary of the ESC, president of the European Association of Echocardiography, and he's an honorary fellow also of the American Society of Echocardiography. He's also the chair of the ESC Guidance Committee, member and of the editorial board of the most important journals of cardiovascular medicine. You may know him for his role in the movie El Zorro. Actually, that was his twin brother, Antonio Banderas. You recognize the similitude. But Pepe is also a very humble individual, very much accomplished, and someone that has developed a friendship with the most important people in the field. We're proud to have you here, Jose, and the team that comes with you today.
Thank you, Mario, for these very nice words. In fact, when we were 30 a few years ago, we met in Madrid, and I've been following Mario, extremely hard worker, always great ideas, always hearing new ideas. And I was very honored when you invited me to your hospital, and I'm very honored to be with all of you. So today, we are going to speak a little bit about the tricuspid valve. And the good thing is that seems that it's an easy valve. But the bad thing, bad news, is that it's really, really, really complex. It's not that easy. So let us start with the anatomy, and let me remind you a few things that are extremely important for the diagnosis and later for the treatment. So remember that from the surgical view, when we speak about tricuspid valve patients, we need to really understand that there are certain surrounding structures that really matters when you start thinking in treating the patient. So also, don't forget that the right coronary artery is quite close to the tricuspid valve. And this is extremely important, for example, when you try to stitch the tricuspid, or the so-called, I will go back to this point later, the tricuspid annulus. So don't forget that also when treating the tricuspid valve disease, you need to think in what happens with the papillary muscles, and this also helps in the reference, the anatomic reference that we need to really search while treating and diagnosing tricuspid abnormalities. Remember that the anterior leaflet is the largest, the posterior is the smaller, and the septal is the less mobile. And we also need to analyze the commissures. The anterior is towards the LVOT, the posterior is towards the right ventricular wall, and the septal is obviously the septum. So, tricuspid valve means always 3 leaflets. This is not the case, this is not true. So remember that this new classification was the proposal by the group of Becky Han, and you can see that there are different subtypes. So type 1 implies the 3-leaflet configuration, type 2, 2-leaflet configurations, type 3, 4, and type 4, 5-leaflet configuration. So this clearly shows that at least half of the valves, they are not type 1. So what happens with the annulus? You need to realize that there is no annulus, there is no tricuspid fibrous annulus. It's not like the aortic valve. So you can see in the histological specimen here that there is no tricuspid annulus. It's really virtual. So why this is important? Because, for example, we treated many patients with the cardiology, so cinching the annulus, but there is no annulus. Then you need to be careful that is an artificial, is a virtual concept that we have created in the separation between the right atrium and the right ventricle. Another, I think, key important issue is the asymmetry in the annular dilatation. So the annulus dilate, but never towards the septum. So it's always towards the anterior or the posterior leaflet. And this is really, really relevant because if you want to treat with a clip, then you need to cinch initially the septum or septum posterior or septum anterior, because this is the single way that you will retract because the annulus dilate never towards the septum that is more fixed. So this concept is very, very interesting and important in order to take your decision. It's not easy to scan, to image the tricuspid valve. This means that you will need to use always all the windows that the, including, never forget, the transgastric approach to image the tricuspid valve. So I think that this is clearly seen, and I would strongly recommend this paper published in JACE in 2022, where you can clearly see the correlations between the image, the DE image, and the anatomy. So what is the problem with tricuspid regurgitation? How big is this problem? So in Sweden, it has been a paper showing that there is an incidence of 2.5 every 100,000 persons a year, and in males, and 2.8 in females. And in the Framingham, the report from 1991, 1995, the prevalence of TR was almost 15%. We did the largest study in Europe, and here more than 35,000 patients entering for different diseases in the echo lab. And we have seen that, well, at least moderate TR is present in 6%. So it's quite relevant, the problem. It's really huge. So we have a lot of patients that we need to solve and give some advice and treatment. So it's really a benign disease. It's not. And it's not in terms of the patients with TR and left side heart disease. It is a severe TR, is associated with poor prognosis. It's not infrequent to see after a pacemaker TR. And again, you can see that the lead-induced regurgitation, you can see that is a marker of worse outcome. It is independently associated with poor prognosis. And this, we have submitted this paper now, and we have analyzed if there is any difference in TR related to gender. And we can see in this graph, still is under review, so we are waiting for reaction. But you can see here that is a high prevalence of severe TR in women. Our incidence, and I will go back to this concept, atrial TR, we have fewer comorbidities, lower index LV volumes, lower index right ventricular volumes, lower TR severity, and improved survival rates. So, in summary, if we consider a patient with tricuspid regurgitation, never forget that we have almost twofold increase of all-cause mortality, 2.5-fold risk increase in cardiac mortality, and 1.7 risk increase on heart failure hospitalizations. So in fact, these patients, it cannot be any longer the forgotten path. We need to do something, because if you have TR, that is poor prognosis. So as you can see, we are dealing with patients with complex anatomy, complex dysfunction, and we have really challenges that I will address later related to quantification and with the treatment, what to do with these patients. So we should look to the disease and not to the valve. This means that in any patient with TR, we should look to the valve, what is happening in the valve. Let us look to the leaflets, the structure, the number, the anatomy, the mechanism of disease, but also the right ventricle, what happens in the evaluation of the right ventricular function, and also the virtual annulus. So the size, the geometry, is it dilated, how much is dilated, and I will go further, I will dive in these different concepts. What is the modern way of classifying TR? So obviously, for years, we've been talking about functional primary. I think this concept is too simple, it's old-fashioned, and we need to move to a new concept, because it's not the same as you see here, the right ventricle, the dentin volume, the annulus, or the right atrium. It's not the same if the patient has a tricuspid regurgitation due to pulmonary hypertension or due to atrial fibrillation. It's not the same. It's not the same disease. This is why I think that we need to go more deeply in the concept of primary, so like Epstein, endocarditis, carcinoid, or in patients with secondary TR. So in secondary TR, you can see that I think that there are different things in the left side valves, in patients with precapillary pulmonary hypertension. So with this in mind, the modern classification, no doubt, that should include atrial TR, ventricular TR, primary TR, or CAD related after a pacemaker or device TR. So if we analyze the primary TR, it's clearly due to intrinsic abnormalities of the valve, for example, a prolapse, rheumatic carcinoma. If we are dealing with secondary, it could be a patient with atrial fibrillation, this is atrial secondary TR. It could be a secondary ventricular, for example, with pulmonary hypertension or a mitral valve disease, so this is secondary ventricular TR. And it could be CAD related, so it could be induced after a leaflet perforation, after pacemaker, or it could be associated with, which means that it's a passive lead that is really not causing the TR. So there are different morphological aspects that clearly differentiate what is the atrial, the functional tricuspid regurgitation, the ventricular or the CAD related, in comparison with the primary TR. So you can see here in this figure the difference in the leaflet fettering, the restriction, the dilatation with the chambers in the right ventricle dilatation, right atrium, or in the right ventricular dysfunction. And it's absolutely different, the behavior in the different scenarios. So this is here an example of a ventricular functional TR. We have the right ventricle is dilated, reduced function, and the tricuspid annulus and the right atrium here is dilated. And the leaflets are, sorry because the video is not moving. And here we have the atrial functional TR, and the ventricle is normal sized and is normal function. But we have dilated right atrium and dilated annulus, and nothing happened in the leaflets. So there is no fettering of the leaflets. Should we think that is related, the atrial secondary TR with the ventricular? And it's not. Atrial secondary TR is not the early stage of the ventricular. So we need to clearly phenotype the secondary TRs in order, because the prognosis and also the treatment could be different. So the first thing to do is to exclude certain aspects and characteristics that are clearly related to ventricular TR. So we have right ventricular systolic dysfunction, right ventricular significant dilatation, tricuspid valve leaflet tethering, pulmonary hypertension. Also, what happens in the LV and in the related to the function or to the valves. So those, they are predictors of survival, but there are exclusion criteria that we should consider. Atrial fibrillation, as you can see in your daily clinical practice, is extremely prevalent. 1 out of 3 patients with new atrial fib develop significant TR in 10 years' time. And there are prognostic aspects that are clearly risk markers for significant TR. Older age, females, permanent persistent atrial fib, and also rate control therapy. As you can see here, those are the risk factors for significant TR in patients with a new onset of atrial fibrillation. So, should we standardize the definition of atrial tricuspid regurgitation? I think we should. Sometimes make it simple or too simple is not the best option. But I think that for standardization of the definition of atrial secondary tricuspid regurgitation, we should think in patients with tricuspid annulus dilatation and absence of tethering, the right ventricle and the LV systolic function are normals. There is a clear predominant right atrium dilatation with an increase in systolic atrium right ventricle ratio, and also the remodeling is also very typical for the atrial secondary TR. But things are not so easy usually. So we have some overlapping features. So there are clear key issues from atrial TR. So this is dilatation and disproportionate RV size and the remodeling. We have clearly on the right part of the figure, you can see the key features of the ventricular secondary TR. But we have some overlapping features that we can see in both. So I think that is very nice and comprehensive to separate the atrial or the ventricular TR, but we need to realize that there are some overlapping features that covers both. What about the outcomes? As you can see in this figure, the severe functional TR in a patient with pulmonary hypertension, very bad news for the prognosis. As you can see here, the atrial functional TR, better prognosis. And as you can see here, the combination of the endpoint of death and any cause of and heart failure and hospitalization is better in the atrial TR than in the ventricular TR. So it seems that the atrial TR is of much better outcomes and prognosis. Also, this is true after an intervention. And you can see here that there is a better survival rate at 2 years after TR in patients in the Euro-TR registry in patients undergoing a TR. So it's better survival, better functional class, and better procedural outcomes. So I think that this is a sign of hope, or that we need to consider when we are dealing with a patient with atrial systolic, atrial secondary tricuspid regurgitation. But let me show this very, very interesting aspect that was recently published. As you can see here, yes, atrial TR is better, but have a look to that. The atrial TR, the prognosis is really worse at a smaller arrow. This means, as you can see, the cutoff point here, that the risk really increases, is much steeper, as you can see there, in patients with atrial TR. So this also means that we may consider an early referral for treatment in moderate to severe TR in patients with atrial TR. And in fact, there is something that is quite relevant and important. Have a look to these curves. So it's not only what happens with the TR, is that if you have a patient with atrial TR and dysfunction, right ventricular dysfunction, this means ejection fraction lower than 20, have a look to the graph. The prognosis of this patient is worse than a patient with ventricular TR and ejection fraction of the right ventricle above 20%. So it's not that easy. We need to consider the etiology, but also for sure what happens with the right ventricular function, and also for sure the pulmonary hypertension. How to quantify? This is again a real challenge in the imaging labs. So we have different ways of quantifying. What is critical is that we need to quantify because it's also related to the prognosis. So it could be done with PISA. It's easy. Now it's almost automatic in the ecosystems, but there are some disadvantages. So PISA, remember, is not validated for multiple or temporally variable jets. It's not accurate with a non-circular orifice that is the majority. And we need to do some flow correction, and lift and angle correction should be used. What are the assumptions of PISA? No temporal variability, true. Round hemispheric flow convergence zone, no, true. Flat surface is not true. And aliasing velocity characteristic that again is not the case. So there are some limitations. We need to know that. 3D vena contracta is easy. It really is a direct measurement of the vena contracta with no geometric assumptions. And also, it's nice to use after an intervention because it can be used after, for example, device placement. But there are always some disadvantages, and there is time variance, limitations of the 3D color, the volume rate, and still there is non-planar orifice. And the validation with the PISA versus the vena contracta have shown some really real variabilities. So in fact, the evidence, in my opinion, the evidence for the clinical usefulness of the 3D vena contracta is growing. And don't forget that the Euro by PISA underestimates the 3D vena contracta by 40%, depending on the shape. So in summary, as usual, we should not use only one method. So what we are using, so the systolic flow reversal of the hepatic veins, well, the vena contracta with it, and we need to average the vena contracta. Also the PISA, we need to quantify and try to do it also with 3D. And this is the best way to integrate all the methods. What about volumetric Doppler? We have some advantages. It's multiple, and the temporally jets can be quantitated. But again, we have some Doppler, intrinsic Doppler disadvantages. This is the assumption of the constant flow across the annulus. It's not true. And the number of measurements, and we really recommend 3D echo here just to be more accurate. This is just very new. Few weeks presented in Madrid in the World Congress in Cardiology 2 weeks ago. And and this is published in the latest version of the ESC guidelines. So we use all the methods, but what is very important here is never forget, assess right ventricular dilatation and function. We need to also assess pulmonary pressures, because with this, we will get the final decision-making strategy in order to decide what to do with our patients. Let me now start with sharing with you some of the things and concepts that in our department we have provided to the literature. So those patients with severe TR are the same. This is why the new grading scheme that we published a few years ago showing that mild, moderate, and severe should move to mild, moderate, severe, massive, and torrential. And in fact, this is relevant because as we can see, we have patients that are really underdiagnosed and undertreated, and this can be changed with the new treatment strategies. So we can see that in different papers, the use of the extended grading classification with massive and torrential has been useful for stratifying the risk of the patient. And in addition to that, the trials are using the extended classification, and we can see that in the Triluminate, in the TRIVALVE, if you go down with 2 grades, moving simply from torrential to massive or moderate, clearly impact in the outcome of the patient. This is our data. As you can see, the survival rates and the hospitalization is even much worse in patients with massive and torrential than even with severe. And in the guidelines already in 2021 in Europe, already recommended the extended grading system. In summary of this part of my lecture, I will say, let us clarify some concepts. So PISA calculates the regurgitant volume easily, the 3D color Doppler again, and the volumetric Doppler, what quantifies is really the regurgitant fraction in a very easy way. We need to quantify, and it should not be only qualitative. What data do we have of worse outcome? What we should look for in our patients with TR? Rocío from our group published the importance of MR, and you can see that the quantitative estimation of right ventricular function and also the severity of TR by MR really predicts the worst outcome in those patients with poorer ejection fraction of the right ventricle lower than 34%. We have also analyzed the ventricular strain. What happens to the right ventricle? And you can see here that if you have a longitudinal strain, a free wall longitudinal strain of the right ventricle with the cutoff value of 20%, in fact, the prognosis is absolutely different using the right ventricular function in terms of the strain. And not only that, we have analyzed what happened with the right atrium function. And this is also very important because you can see that analyzing what happens in the right atrium, you can see that patients with a cutoff value of 9.4% in the right atrium reservoir strain, this is really associated with a 3.2-fold increase of risk of heart failure or cardiovascular death. Remember that years ago we still use the Tay index, trying to combine the diastolic and the systolic function. So we created the Stray index, combining what happens in the strain of the right ventricle and the strain of the right atrium. You can see here that in patients with the Stray combining atrial and ventricular dysfunction, those are clearly showing the ones with worse outcome. Clinical relevant information, and this idea was done by Ariana, which is sitting here, and she is the head of valve clinic in Madrid, and she did this 4A classification. Why? Because we are using, even with the trials, we are using the New York Heart Association classification, but the New York Heart Association classification was done for left heart failure, not for right heart failure. So what happens in a patient with right heart failure? So we have asthenia, ankle swelling, abdominal pain or distension, and anorexia. And you can see here, and this was our previous data, and now we have in their evaluation a larger group from different hospitals, showing that the 4A classification, this means A0, no clinical data, no present, A1, 1 is present, A2, 2, and A3, 3 or 4 present. And you can see that you can even predict what is going to happen if the patient has asthenia, if the patient has abdominal symptoms, if the patient has ankle swelling or anorexia, which is really, really a drama. So I think that we should use a score of what really matters, the right heart failure. I think that the NIHA classification for just predicting what's going on with a patient with atrial TR is useless, because it's not really the cause of or it's not really related to the disease. And more recently in JACC, we published who are the ones, because TR sometimes is really dynamic. We have patients that really progress, and there are other patients that they don't progress. So who are the ones to progress? Because if we know who are the ones to progress, maybe we should treat earlier. Or if we know, we have not analyzed that part, but if we know who are the ones not progressing, maybe it's futile. If we treat them early, we don't know still. But who are the ones clearly progress? Older age, lower body mass index, chronic kidney disease, atrial fib, or right ventricular dilatation. And we have here patients that are non-progressors, and we are even analyzing the regressors, because as you know, TR is very volume dependent, so it's really affected by the medical treatment. Something else, sorry for the extra ink that we have here. So we have also analyzed genes. We do genetic testing for cardiomyopathies. We do genetic testing for sudden death. And we imagine a genetic testing for valve diseases. We analyze what happens with microRNAs in functional with tricuspid regurgitation. And we have seen that there are some microRNAs that really predicts heart failure and all-cause mortality. It's an ongoing project, and maybe we have some genes that really affect what happens in the valve. And finally, how to treat. Well, those data are coming from the US. The data published in the ESC guidelines are even worse. But don't forget that the tricuspid valve surgical intervention is not that easy. The mortality rate here is close to 8-9%. Europe, the guidelines is 12-13%. So it's not that easy. You need to think in a very enormous surgical team and with great results. So it's not that easy to send a patient to surgery with isolated severe TR. In fact, the TR begets TR. If you think about that, if we have this vicious secondary TR circle, you can see that it's so easy to think that this patient usually progress. So when we should treat, because it could be too early or it could be too late. So knowing that, as we have seen, it's not a benign disease. Medical treatment, then we treat the congestion. Okay, I agree with that. So in patients with secondary TR and the patient has a heart failure, then we treat according to the heart failure guidelines. Have a look that sometimes the patient is too late when we go to the precapillary pulmonary hypertension. But this is the medical treatment that we use to treat congestion. So what happens here is this ongoing disease that it went from very mild or non-symptoms to irreversible organ damage. So we need to really think and stratify the risk in order to set the proper time for intervention. We have new options. So we have valves that we are implanting. I'm sure you're implanting here also a lot. We have the possibilities. Those are the ones with CE mark. We did a lot of Cardiovan. Now it's not any longer available in Europe, but we had very nice results. And even we have patients that we have treated with the Cardiovan, have reduced the annulus, and later we have added a clip. So we have the Pascal, the Triclip, the Cardiovan, and also we have a lot of experience with the Therapeutic trick valve. Well, think about the best candidates for TEER are the ones in the gray column. We have for annuloplasty. Those are the ones that we did as with the Cardioband. We have for the valve, and we are doing the Evoke, and we have the Bicava also approach. But you need to, I was the one analyzing as a central core lab the study, the European study of the Bicava. And the thing is that if you are doing that too late, then the right ventricle will collapse, because you really stop the flow, the reversal flow, with a prosthesis in the superior vena cava and the inferior vena cava. So if it is too late, then it will be also too late for the ventricle. This means too late for the patient. Again, coming to an end, this is what we do recommend, published 2 weeks ago in the guidelines. So let us go to the left. There is no need of left-sided valve surgery. What we do, if we have a severe primary or secondary TR, if we don't have severe dysfunction of the ventricles, if the patient is symptomatic and the patient is not appropriate for surgery according to the heart team, then we should think or in the TEER, or even we should think in surgery. So I think this is the figure that we are following, and this is what we are following in our hospital also. But remember that you need to really have an excellent surgical team, because this is not an easy surgery, and the event rate after surgery is quite high. So this is the classification now we have for the transcatheter tricuspid valve treatment should be considered. So it's a 2A indication to improve quality and remodeling in high-risk patients with symptomatic severe TR despite optimal medical therapy. I think that optimal medical therapy is what usually we think we do, and non-optimal is what the others are doing. But, so it's very difficult to say what is really optimal, but it's a 2A. So what is the ideal patient? It has come to an end. Who is the one? I think that this is the balance that we need to really think. We're moving from the medical therapy, low risk for intervention, maybe too early, or you go when it's really, really too late, and it could be futile. So we know that the procedural success independently is predicted the time of free death and admission according to the success rate, obviously, and how to also analyze this paper coming with the Triluminate, where we have seen quality of life, but not real outcomes. Maybe with these key exclusion criteria, severe pulmonary hypertension, severe right ventricular dysfunction, LV ejection fraction lower than 20, maybe it was too early, or it's the wrong population. I think that we still have questions without a clear answer. We classify the patient risk according to the TRI score. This is the data that we consider for the score. And you can see here the low TRI score is lower than 3, intermediate 4-5, and high TRI score is more than 6. And you can see in blue the patients with tricuspid valve repair, and in red the conservative management. And what is the main result in the three registry in Europe? Well, I think that the most important thing here is that you can see that the benefit, the real benefit, according to the score, what really impacted is the survival progressively, as you can see, going to the right, decrease with the T-score, irrespective of surgery or percutaneous, and the early surgical or transcatheter intervention is seen in patients at low or intermediate T-score. No doubt that the quality of life improves, and then we need to think if what we expect. Do we expect lower mortality? Do we expect quality of life? What is the risk benefit of a specific intervention? So at the end of the day, we still don't know how early we should treat. We still need more data how early we should treat. Or this is an ongoing study that we are doing, a multi-center study. Who are the ones that we should not treat? And we already treat. So the futility of an intervention is already there. In conclusion, TR is a complex problem. The valve, we should not only look to the valve, we should look to the whole problem. The severity is linked to the survival and the outcome, but remember that even mild TR gets some worse outcome. How to quantify is multi-parametric methods. We should also see the right atrium function. This is crucial. We need we need really experts to analyze what happened after the intervention to quantify the severity, the residual severity of the disease. And this is a figure that is coming in a paper from us showing how important is the approach for the multimodality imaging, how important is the clinical data, the 4A, how important is to manage the patient with the congestion and diuretics. Even we should treat with diuretics before the intervention more aggressively. And then we have the treatment. Then we need to decide when and how according to our results. Remember, we have a lot of information with all the imaging modalities. This really helps, but use your own brain. Thank you very much.
I think you will all agree this was one of the best grand rounds that we have heard in a long, long time, and definitely the best lecture I have ever heard in tricuspid valve disease. Now, I'm curious about one of the last few slides that you showed. You clearly mentioned, I believe wholeheartedly, that patient with pulmonary hypertension should continue with medical management. Of course, we've seen a few patients with pulmonary hypertension that have undergone repair or replacement tricuspid valve, and the right ventricle falling apart, and the patient developing hepatic failure and so forth. But I wonder, is the converse also true? I have managed a few patients with Fontan, taken them through pregnancy, no symptoms, they do quite well, they don't have any tricuspid valve. We have a lot of patients here in the Bronx with endocarditis that have no tricuspid valve. You see a normal sized right ventricle. They have no symptoms of right-sided failure. I assume they probably have low pulmonary vascular resistance. So the question is, should we, instead of excluding patients with high, maybe we should also include in patients with low?
Yeah, I agree with that. We published like, well, I think it was in the 20th century, but we published in JACC patients with HIV and endocarditis. We removed the valve and we didn't intervene with a prosthesis. We certainly removed the valve and that's all. And we have seen survival rates in the I would say mid-term years without any valve there. So I think that this may be also, I am sure that the patient with precapillary hypertension is too late. And we should have been done something before. But the other one, we also, I don't have any solid data to answer that, but I think it's something that we at least consider.
Questions? Mike?
Thank you very much for the talk. You had mentioned that if it's too late, specifically in the bicaval valve, you see the RV fail. I guess two questions on that. Do you think you'd see similar issues with things like clipping specifically? And also, how do you all define too late? Is it imaging? Is it invasive hemodynamics?
So I'm gonna repeat the question so the people that are remote. So Mike is asking whether if how do you define when it's too late to do an intervention in summary?
Yeah, with the bicava, if the right what I have seen, even with being the central core lab for the European study, is that the ventricle, if it is already impaired and you close the orifice, so the backflow, then the ventricle dilates and the function, the right ventricular function, really go deep down. So is that the case with clipping? Well, the thing is that with clipping, you really don't close all the regurgitant flow. It's not like you go to zero. So I think that it may help in such cases with right ventricular impairment just to give some room to backflow that preserve in some way the pressure in the right ventricle. So I think when it's too late to close is when you see that at the beginning, before the intervention, the right ventricular is dilated and the function is really impaired. Then I will think it's too late. But maybe it's not so late for the clipping.
So, as an electrophysiologist and having implanted many thousands of leads across the tricuspid valve, it's a lot of tension right now, and I think legitimately, we're not sure what the right answers are about CIDs, whether to extract, whether not, whether the lead is the cause, whether even if it isn't the cause, would interfere with the delivery of the valve, or you can deliver the valve, but then you compromise potentially the function of the lead. I can tell you, we're about to publish the 2026 guidelines on lead management, and this is a raging, I think we spent 30% of our time yelling at each other about what to do, and that was just the electrophysiologists. So where should we be looking in this and for the future? Should we be doing more leadless devices in general? What's the perspective from your world?
So the question comes from Dr. Gross, basically, who states that electrophysiologists routinely yell at each other. The imaging world as well. But the question is really about the role of lead extraction. I mean, are we underdoing it, overdoing it, when it is absolutely necessary, and when we can get by with letting some degree of regurgitation present?
I think it's an excellent question. We also get usually excellent question from our EP team. The thing is that we don't really like lead extraction. We are moving to the physiological stimulation. But at the beginning, I was thinking that we were simply changing a ventricular problem to a valve problem. But the data showing that with the physiological implant, the leads, it's not really causing more problems with the septal leaflet. After saying that, I think that in the future, what I will expect is that we will implant more pacemaker without leads. That's what I think will. And now that we have the bi-chamber pacemakers, I think this is going to be the trend. Still, we do have a problem with cost, obviously, but I think that we should not underestimate the prognosis of TR after CAD related. But we try not to do the lead destruction, only in very severe cases.
I just sort of felt since the contribution of CIDs to TR is an area of uncertainty, should there be some sort of new registry or everything that every patient who gets a lead across the valve should have with some standard measure of TR, and it should be built in as part of the follow-up, that it should be followed over time to determine, causality as opposed to association?
Exactly. I fully agree with that. I mean, we need solid data with control before and follow-up of all those patients to get the final answer to what is the real impact of the lead, because maybe some patients, they do have a TR before the implant and we don't know it, and then we think that this is related to the lead and maybe it's an added issue, but it's not the real cause.
Scott?
You had two classification systems in your talk, the 4As and the new levels of severity. I'm going to guess that the 4As show up mostly in the two higher ends of your severity score. Is that correct? Or do they become pertinent sometimes in lower levels, the traditional score?
The question from Scott is about the classification of severity.
Yeah, the 4A classification, and thank you, Scott, for this question, is mainly related to prognosis. So I will say that is the mirror of the New York Heart classification for the left side, is the mirror for the right side. So it's more related to prognosis, and it's very easy because it's really clinical. I mean, you get that very fast. You have it always in your clinical file. And this means it's not related to severity of the TR, but is related to the severity of the disease, which is different.
Yes, when dealing with these patients, it's clear like on both extremes, the atrial functional TR and the ventricular functional TR, when they're like classic phenotype, they're like very easy to differentiate. But when dealing with these databases, sometimes we have these patients with overlapping features. So how was your approach in terms of like classifying and putting in these groups? Because in the end, we gotta either exclude them or just trying to see where to put them. What was your approach in dealing with these patients?
Question from Juan is how to classify atrial from ventricular TR. I will expand that and say, how can you ascertain that the prognosis is due to that classification versus the comorbidity that is causing that abnormality?
Exactly. I think that the main issue here is that the classification is simple, but life is not that simple. So if we see a patient with atrial fib, clear sign with atrial TR, and everything fits, then it's true what we know about prognosis, gender, how to treat. If the same will apply for the ventricular, but the mixed phenotypes, I think that we should then be the art of medicine to really think what is more and more important, or try to balance through ventricular or atrial. But I think that at the end of the day, those patients really start on a certain, the beginning of the disease is what really matters, how it went during the follow-up. Then you can go more for the atrial aspect or more for the ventricular aspect.
Thank you for that great talk. On the left side, in patients with atrial functional mitral regurgitation and atrial fibrillation, there are some who think that the rhythm control strategy can sometimes improve the mitral regurgitation. Is there any evidence of this on the right side with TR and atrial functional TR and AFib?
Good question is the role of rhythm control, rate control, or both for reducing regurgitant volume. on the right side, since there's data that supports that for the left side.
Well, since still there is some controversy from the EP, aspect, that is still for the valve, I think that the rhythm control is better. And there are some signs showing that as in the mitral regurgitation, the TR will benefit from rhythm control.
Thank you for the talk. Really, really great. Just two questions. So we've seen that very recently there was also a paper on moderate MR and how it impinges on clinical outcomes. And I really like the point of moderate TR, which is, sometimes might be residual after intervention. A lot of studies have actually looked at endpoints being moderate or less. I'm just wondering if you think that we should maybe revisit, or according to what you said in terms of atrial functional TR, or if there's anything that we can look a little bit more in depth to see how patients do afterwards.
That's a complex question from Dr. Pascual Leon, and we have a very diverse group here. You can see here, although there are a couple of peaks here that are outliers, the Hispanic and the Italians. Italian school of thought here, also from the interventional part of it. So I'll let you address that directly.
Well, Pasquale, this is a very too Italian question. So, to be honest, I don't have an answer for that, because I think we still don't have enough scientific data and studies focusing on that, that we can get a final. It's typical question I usually call Mario. Don't have an answer really for that solid answer.
And just one more question. What's your typical patient that you are candidating for a CABL valve? And what's the proportion of patients in your clinical practice that you have to offer orthotopic valve replacement, heterotopic or CABL valve implantation, and TEER?
Well, we do have Luisa here, who is she is really the expert in the cath lab implanting all types. So we are doing all. We do the clipping, we do the valve, we do the bicarb, and we have a lot of experience with Cardiology, although Cardiology now has stopped. So if we have a clear annular dilatation, then we have started with the Cardiology, and with residual, we have clipped the valve. Patients for the evoke, for the prosthesis, or we usually tend to do that, or our experience was in those patients that the annular is not really so much dilated, and we have the potential easy way to attach the valve. It's not that easy from the imaging, because even with the transgastric, there are some parts of the annulus that are difficult to image. But and for the bicarb, that also I think it's an easy procedure. But we are still doing that when it's too late. I think it's simply too late. The bicarb improves the quality of life, but we don't have data for survival rate, so it doesn't really improve survival. But for the quality of life help, we are doing that as a late stage in the disease.
All right, so if we have any additional questions, we will have you join our fellows for a session. Thank you again for